Hi, everyone. This is Dr. Weaver, and I am coming to you to provide you with some information regarding the hematologic system. I thought I would go over this information in class, but we have so much to cover. I thought I'd better go ahead and do a couple of PowerPoint voiceovers to make sure you have this information. This is Adult Health 2, Chapter 39. Again, this is assessment of the hematologic system. So this PowerPoint is essentially an overview of anatomy and physiology, as well as assessment of the hematologic system. And I'm going to have you to read a lot of this information. Of course, you have to read everything anyway. But you will also have this PowerPoint presentation to assist you with your reading. And again, this is Chapter 39, Assessment of the Hematologic System. And of course, the picture that you see is a normal red blood cell. And so some priority concepts for this chapter are clotting, as well as perfusion. This all has to do with the hematologic system, so that just makes sense. So as far as a quick overview, perfusion, it is the total arterial blood flow through the tissues, which is referred to as the peripheral perfusion, and also blood that is pumped by the heart, which is known as central perfusion. This is what pumps our blood throughout our total body system. Now, as far as clotting, it is a complex multi-step process by which blood forms a protein-based structure, which is called a clot. Clots are proteins. This clot forms in certain areas where our tissues are injured. And this prevents actually excessive bleeding. This helps to maintain a whole body blood flow. Now, the hematologic system consists of blood cells, our lymph, and organs involved in blood formation. Our body system depends on blood because of its rich oxygen and nutritional contents. If there is a problem with the hematologic system, our total body is adversely impacted. So class, again, this is an overview, or a review of anatomy and physiology of the hematologic system. We will be discussing bone marrow and also blood components such as plasma proteins, red blood cells, white blood cells, as well as platelets. And we will also discuss the accessory organs of blood formation, such as the spleen and the liver. Now, the bone marrow is responsible for formation of red blood cells. Red blood cells are also referred to as erythrocytes. It is also responsible for white blood cells, which we refer to as leukocytes, as well as platelets. The bone marrow is involved in immune responses. Cells producing in adults takes place in flat bones, and of course your flat bones would be your sternum, your skull, pelvis, as well as the shoulder girdle. And as a patient ages, fatty tissue actually replaces the remaining marrow. So you may find that these patients are more anemic and have other low counts as a result of aging. Now, the bone marrow first produces blood stem cells. And so you may ask, what are these? These are essentially immature. These cells are unspecialized or undifferentiated cells capable of becoming any cell. So essentially, before they become any cell at all, before that, they're basically immature. You don't know what they're going to turn into or to become. So at the early stage, they're just essentially immature, unspecified, or undifferentiated cells ready to become whatever the body needs. As far as blood components, blood contains plasma as well as cells. Our plasma is extracellular fluid that is similar to, if you've ever seen the interstitial fluid that is found between tissue cells. It actually contains more proteins, our plasma. It contains more proteins. Now, there are three main types of plasma proteins. The first one is albumin, and albumin maintains what we call osmotic or oncotic pressure. That PSI of the blood is pressure of the blood. And basically what happens is it keeps the plasma that is within our vascular system from leaking into our surrounding tissue. As you know, when when plasma begins to leak into our tissues, then we get what we call edema or swelling. But this albumin, which is a protein, it forms a kind of a pressure that keeps blood within the vascular system, or the first space, as we call it. We also have globulins, which is also another protein, and it does have many functions. It does transport other substances such as antibodies. It protects the body also against infection. So think about the immune system. Fibrinogen, this is activated this substance is actually activated to form what we call fibrin. And this is all critical for the clotting process. So think the clotting mechanism when we're thinking about this particular protein. Now, red blood cells or erythrocytes, they are the largest portion of the blood cells, and their normal range is between 4.2 and 6.1 per liters. Our red blood cells produce hemoglobin, and it carries iron, which is important in acid-base balance. Iron also carries oxygen as well as CO2. The most important feature of hemoglobin is its ability to combine loosely with oxygen. If you can look up the term oxygen dissociation, you want the oxygen to be loosely tied to the hemoglobin, because when your tissues are needed, then it easily gives up the oxygen molecule and, of course, supplies our tissues and organs with enough oxygen. There is a total number of red blood cells. There must be a total number of red blood cells in order to have good perfusion with oxygen, and also for clotting. So you do need enough of the red blood cells for those purposes. Now, if a patient has too many of the red blood cells, your red blood cells become very thick. Your blood becomes very thick, and it flows very slowly, which can cause clotting. So just think about balance. It's all about balance. It's all about homeostasis. Now, as tissue needs increase, more red blood cells are produced. So when our tissues are more or less starving for some oxygen, then red blood cells will be produced in order to supply it with oxygen. As far as our kidneys are concerned, our kidneys produce a red blood cell growth factor known as erythropoietin. This is a growth factor, and it produces it at the same rate as red blood cells are destroyed in order to maintain circulating normal levels of red blood cells. So again, we're talking about balance. So as red blood cells are being destroyed, this growth factor erythropoietin is produced in order to increase the good red blood cells, while the old ones are being destroyed. Now, tissues that have low oxygen would be referred to as hypoxia. Remember, low amount of oxygen in the blood is hypoxemia, but in the tissue, it is referred to as hypoxia. Now, our kidneys release more of this erythropoietin, and again, this increases red blood cell production in the bone marrow. So the erythropoietin stimulates the bone marrow to produce the red blood cells. We also have some synthetic drugs that we use, ESAs, such as what they're referred to as erythrocyte stimulating agents, such as Procrit. You'll see these in the hospital, Epogen, and also EPO. It has the same effect, these drugs have the same effect on the bone marrow as just like your naturally occurring erythropoietin, the growth factor. It acts the same, but it's just a synthetic form. Now, iron, B12, folic acid, copper, pyridoxine, cobalt, and nickel, all these elements are necessary to form hemoglobin and red blood cells. If these patients are lacking in these elements, this can lead to anemia. It leads to tissue hypoxia or unmet tissue needs. The tissues will not get what it needs as far as oxygen and what have you. Now, white blood cells are also formed in the bone marrow. There are many types of white blood cells, and they have specialized functions, and they do provide protection through the inflammatory and immunity process. We'd like for you to take a look at table 39-1 for these functions. Platelets are the third types of blood cells, the smallest of the three that are formed in the bone marrow. And these are formed when or necessary when the patient is injured. These platelets, they actually stick to the injured blood vessel, a wall, in order to form what we call a platelet plug. And this essentially stops blood flow at the injury site, so people won't bleed to death. Platelets produce substances important for blood clotting and aggregate. When we talk about aggregate, we're talking about how these platelets clump together. It does this in order to perform most of their functions. So platelets are very important, and we'll talk about the clotting process later on. But without the clotting, process, then our coagulation system would likely fail. So we do need the blood clotting process. It actually starts the clotting process. Again, we'll be discussing that a little later. Some more information regarding platelets. It keeps small blood vessels intact by starting a repair after damage has occurred. So this is when our platelets will kick in. There has to be some damage to our blood vessels, and it is what helps to these platelets. They help in the repair process. Platelets, when they leave the bone marrow, they are stored in the spleen, and they're released slowly to meet the body's needs. So as the body is injured, more and more is released. About 80% is circulating in the blood, and another 20% is stored. Now, as far as the accessory organs of blood formation, the spleen and the liver are considered accessory organs for blood production. And it helps to regulate blood cells, and it forms growth factors to ensure that clotting takes place. Now the spleen is involved in blood cell production and the destruction process. Again, think balance. As these blood cells are produced or as blood cells are destroyed, others are produced. And so again, we have this balance. The spleen is also involved in immunity. The spleen contains what we call white pulp tissue, which is a major site for antibody production. So as blood filters through the spleen or white pulp, bacteria and old red blood cells are removed. Um, the red pulp, the spleen also has tissue referred to as red pulp. And this is where red blood cells and platelets are actually stored. Other functions of the spleen destroys old or imperfect red blood cells because some red blood cells are imperfect. It breaks down hemoglobin that is released from these destroyed cells. It stores platelets and it filters antigens. When the spleen is removed, as you know, some people, they might have a splenectomy, perhaps because of some trauma, what have you. These patients, as you can see, as I mentioned earlier, how the spleen has some immune properties. Once the spleen is removed, the patients do have reduced immune functions and increased risk of infection and sepsis. This is why these patients have to receive inoculations such as pneumococcal inoculations or immunizations in order to help protect them, since the immune system is compromised a bit. The liver also produces prothrombin and other blood clotting factors, which we will discuss a little later. It also forms vitamin K in the GI tract. Vitamin K is also needed. It is a needed clotting factor. Those clotting factors are referred to as 7, 9, and 10, and prothrombin. We'll discuss these as well. The liver stores a large amounts of whole blood and also blood cells. It also stores extra iron with protein ferritin. So the information that I'm getting ready to go over with you, I will just kind of forewarn you. It's kind of a sort of a complicated process. It's not too bad, but I just really need you to just listen up. We're going to discuss what we call homeostasis and blood clotting. Not homeostasis, but homeostasis. And of course, homeostasis is a multi-step process of controlled blood clotting. Um, it also, we're talking about platelet aggregation. This is when platelets are clumping together. We're talking about blood clotting. We talk about intrinsic factors versus extrinsic factors, as well as the fibrin clot formation, which is the last step in this multi-step clotting process. So this homeostasis results in localized blood clotting that occurs in damaged blood vessels in order to prevent excessive blood loss while our blood is actually perfusing through the vascular system. Um, and basically this perfusion, we're perfusing the rest of the body, but of course we have to plug that damaged vessel so that blood does not leak into the damaged vessels and these patients bleed to death. Now, there is a balance. There's a balance between blood clotting actions. In other words, our blood, there's these steps that has to take place in order to form a clotting. But there's also a process that is known as anti-clotting actions. So you don't want too much of either one. You want the clotting actions in order to form a clot when necessary, in order to prevent a patient from bleeding to death. We want the anti-clotting process to come into play. We want to shut down that clotting because too much clotting can, of course, form clots and could actually hurt or harm your patients. So you have the clotting actions and the anti-clotting actions. Again, you don't want too much of the clotting, but yet you want clotting only when appropriate, right? Now, there are three sequential processes that lead to clotting. First, there must be platelet aggregation. So when these blood vessels are damaged, platelet aggregation, these platelets that are circulating singly throughout our blood system, they will begin to aggregate and they will form what is called a platelet plug formation. Now, once this platelet plug forms, this is when the main clotting process, that blood clotting cascade is what we refer to it as, will begin to kick in. And of course, the end result is the formation of a complete fibrin clot, that clot that will stop any bleeding in these patients who might be injured. So another way to view it is, so the platelet aggregation begins forming a platelet plug by these platelets, as I said, beginning to clump together. And it is this platelet clumping that is needed for the clotting process. Also note, normally platelets, I mentioned this before, platelets actually circulate as individual small cells that don't clump together until they are activated. An injury can activate this clumping of the platelets. Now, after activation, these platelet membranes become very sticky. And it is the stickiness that leads to this clumping together. And it forms a large semi-solid plug in the blood vessels. And this can disrupt blood flow locally. But note that these are not clots, and they last only for a very short period of time. As I mentioned before, this only starts the process of hemostasis process, or this clotting process. Now, if a patient has too few, very little platelets, it can lead to increased bleeding. So now the platelet plug starts the process, which triggers blood clotting. Blood clotting has a more amped up or larger part in this cascade. So keep that in mind as well. Now we have a couple of concepts. One is called intrinsic factors versus extrinsic factors. The intrinsic factors are those mechanisms within the body that will trigger this cascade. So with the intrinsic factor, it means that in order to trigger or to activate platelets, hence the clotting cascade, these patients must have conditions like some circulating debris or kind of a venous stasis to continue the blood clotting cascade, which will require adequate amounts of all the clotting factors and the cofactors, which you will also read about. Now, the extrinsic factors, which is outside the body, extrinsic, outside the body, factors that initiate platelet and clotting cascade. What happens here is trauma. These patients have trauma to their blood vessels, and once that trauma occurs, there's this collagen that is within the walls of the blood vessels that becomes exposed. Now, other blood vessels can also activate platelets as well. And what this leads to is inflammation, or rather other processes such as inflammation, bacterial toxins, or foreign proteins can also activate platelets as well, is what I meant to say. Now, the intrinsic and the extrinsic factors both result in a fibrin clot and local blood clotting. Ultimately, that's the outcome that we do want. Now, there are specific clotting factors. There's calcium, and more platelets are needed to start the cascade of platelet plug that will eventually become a fibrin clot. Now, these clotting factors are actually inactive enzymes. that become activated in a sequence. And of course, at each step, the activated enzyme from the previous step activates the next enzyme. So it is a step-by-step process. But as one enzyme is activated, it will help to activate the next step in that sequence or clotting process until, again, we get a fibrin clot. Now, the last steps of the clotting cascade, it activates what we call thrombin, and this thrombin comes from prothrombin. So you have thrombin first, and you have prothrombin first, and thrombin, which is the next step, will be activated thereafter. Now, then we have a conversion by the thrombin of what we call fibrinogen into fibrin. And this fibrin molecules form the true clot. Without the fibrin molecule, then you will not have a true, strong, and stable clot. So it's that step-by-step process that I want you to just understand in your reading. Now, the fibrin clot formation is basically the last phase of blood clotting. Now, this fibrinogen is an inactive protein that is actually made in the liver. The activated enzyme called thrombin, it actually removes the end portions of that fibrinogen and converting it to an active fibrin. When linked together to form fibrin threads, the fibrin threads make a kind of a mesh, kind of like a mesh-like base in order to form the blood clot. It is this mesh. When the fibrin mesh is formed, clotting factors 8, it tightens up that mesh. That mesh is kind of like the frame, if you will, where all the clotting material will begin to fill in these spaces, if you will, the mesh spaces and whatnot. When it does that, this mesh now becomes more dense, it becomes more stable. More platelets do stick to the threads of mesh as well, and they attract other blood cells and proteins also. This is what actually forms an actual clot. As the clot tightens or retracts, there's a serum that is squeezed out of it, and once that occurs, then your clot formation is complete at that time. So just go ahead and look at that multi-step process, and hopefully it will begin to make more and more sense to you. Just remember, you have one enzyme. For example, if it was a 7-step process, number 1, that enzyme has to activate number 2, and number 3, and so forth and so on until you get that fibrin clot. So now we're talking about the anti-clotting forces here. Remember, you have to have clotting forces, and then you have the anti-clotting forces, and what they're essentially doing is they're in balance. You don't want too much clotting, but yet you need clotting in case the body actually needs it. Now, blood clotting is a rapid. Excuse me, everyone. It looks like Siri wants to talk. Anyway, so the blood clotting is a rapid cascade process. Once the clotting cascade starts, it affects the entire body. Now, these anti-clotting forces also start in order to limit clot formation to only damaged areas, so that normal perfusion can continue everywhere else. I mean, you don't want a systemic effect. You just want essentially that local area to be repaired, to stop the bleeding in the local area. So again, the anti-clotting forces come into play in order to bring about that balance. Now, with blood clotting and anti-clotting occurring in balance, the clotting only occurs where it is needed, as I mentioned. Again, the general body perfusion at this point is not impacted, and you don't want it to be. Anti-clotting forces ensure activated clotting factors present are in limited amounts. And of course, with the anti-clotting forces, it brings about what we call fibrinolysis. Lysis meaning you are destroying the clot when needed, of course. So fibrinolysis is a process that dissolves fibrin clot edges with a special enzyme. And I would like for you to look at or see figure 39.5 for a visual on this process. Fibrinolysis. Plasminogen is activated, and it forms what we call plasmin. And plasmin, which is an active enzyme, it actually digests. Remember, this is the anti-clotting process. It actually digests the fibrin, the fibrinogen, and also prothrombin. And this actually controls the size of the fibrin clot. Want you to also note there are anti-clotting substances on page 800, so make sure you read that information as well. These are actually needed to prevent clots from becoming too large, forming in areas where they're not really needed. So again, it is that balanced process that we need. Now, deficiencies of any anti-clotting factor increases the risk of pulmonary embolism or an MI or CVA because if the clotting is unchecked by the clotting cascade, or if this clotting is unchecked by the anti-clotting factor, then blood clots will continue to develop and put these patients at risk, as I just mentioned, PE, MI, and also CVA. So, of course, getting old is not fun all the time. Aging does change blood components. There's a decreased blood volume with lower levels of plasma proteins. And this is likely due to low dietary intake. Dietary intake of proteins and reduced protein production by a liver that is getting older. Want you to also read read chart 39-1 for how to perform a hematologic assessment of older adults. Very important read. Antibody levels and responses lower and slower, so the immune response is impacted. White blood cells do not rise during infection like it does in younger population as well. The bone marrow also produces fewer blood cells. Red blood cells, white blood cell counts are lower. Platelet counts do not change. That's about the only one that doesn't change. Lymphocytes are less reactive to antigens. You know, antigens are those foreign substances that the body must recognize and fight against. So these older adults, they lose this particular immune function. Hemoglobin levels fall also after middle age, possibly due to or related to iron deficient diets. So here again, teaching becomes very important, so we must help these patients to maintain diet rich in iron. So as far as assessment of patients with hematologic issues, age and gender, when we consider those, bone marrow function and immune activity decreases with age. As far as liver function, You want to ask about signs and symptoms that might point to liver problems like jaundice, anemia, as well as gallstones. As far as radiation treatment for cancer, it can damage the bone marrow, um, itself, affecting hematologic functions. Um, and as far as drug use, it points to legal and otherwise. I mean, could be illegal drugs, which can also impact the hematologic system. There's also dietary patterns. Remember, poor nutrition can certainly impact these patients hematologically. As far as socioeconomic status, it can impact their health too. Remember, these patients cannot afford proper nutritional diets. Um, when we look at or consider occupation and some hobbies, some of these activities might impact these patients, especially if they are exposed to certain agents that affect the bone marrow. So you want to ask these patients if they live near an industrial sites. These waste products that these companies put out in our environment can impact these patients, their hematologic system. So you want to ask about that in your history. You want to also know the location of their home. Homes could be located near previous waste dump sites, or these might be homes where lead paint was also used. Now, use of blood thinners. Um, you want to discuss that with your patients as well. NSAIDs, these medications can also impact the clotting activity. So I want you to look at page 801, table 39-3 for more information about drugs that can impair the hematologic system. These drugs can prevent new clots from forming and or limit or prevent extension of clots. So these patients can bleed to death. Anticoagulants do not break down existing clots. I want you to keep that in mind too. Once clots have developed, anticoagulants that we give these patients will not break down those clots. Now, as far as classification of these drugs, they are referred to as direct thrombin inhibitors. They are also called indirect thrombin inhibitors. Remember that thrombin, prothrombin, and the fibrinogen and so forth is all a part of that cascade process. And so if you're trying to stop these patients from clotting for whatever reason, then it is these inhibitors, these drug inhibitors that will prevent that process. Vitamin K is an antagonist. I want you to read, this is when these patients are bleeding too much. You want to give them vitamin K to stop the bleeding. Read also page 801 about these specific drugs. So as an example, let's take a direct thrombin inhibitor, drugs such as I think is lepidolin, and also argatroban and Eliquis is another one. These drugs do the following. They prevent the conversion of prothrombin, which is referred to as factor 10, to its active form. Remember each preceding enzyme in the cascade process must, a protein should I say, must be activated before the next step will take place in that cascade process. So these particular drugs, they prevent the conversion of prothrombin factor 10 to the active form. And then you have thrombin, which is factor 10A, that forms as well, or rather that is unable to be formed. And so when a patient has less thrombin, let me kind of go back. So the drugs, they do prevent prothrombin, which is factor 10. They prevent its active form, because once prothrombin becomes active, then it changes into thrombin. So we're on our way to forming a clot. Thrombin is also referred to as factor 10A. Now, given this particular drug, prothrombin would not um, uh, change over to or become thrombin, so there would be less thrombin available. And of course, less thrombin disrupts the clotting cascade by reducing the amount of fibrinogen, which is converted to the active fibrin. Remember, fibrin is the actual clot. All right, and so these drugs just basically interrupts or disrupts that clotting cascade multi-step process is what I need you to understand. So we're still looking at assessment. Let's talk about the nutritional status. We'll also talk about family history and genetic risk, as well as current health issues. As far as nutritional status, poor diets can adversely impact or alter cell quality and affect clotting. So if they've been eating foods that are rich in iron, protein, minerals, or vitamins, which are all the required proper cell, all that is required rather for proper cell functioning. If they're not consuming these nutritional diets, otherwise it can lead to anemias of many types. These patients who eat diets that are high in fat and carbohydrates, they will likely have nutritional deficiencies because in order to produce our blood cells, particularly our red blood cells and platelets and so forth, you need a nutritional, a well-balanced nutritional diet, adequate diet. A diet that is high in vitamin K, such as green leafy vegetables, does increase clotting. So check for salads and other raw vegetables during your assessment to determine if these patients are consuming this. So you want them to be able to limit the green leafy vegetables. You want to also ask about alcohol consumption. Usually results in nutritional deficiencies as alcohol does impair the liver and it reduces blood clotting. Socioeconomic status, we think about financial, personal resources that can be revealed if a patient is not getting adequate nutrition. These factors can play a role in that. And of course, we look at family history, genetic history, which can also impact our ability to produce blood cells, clotting, and so forth. You think about your the hemophiliacs and whatnot, and just can be a family history. Family history is important because disorders affecting blood and clotting can be inherited, as you know. And again, you want to ask these patients about health histories like the hemophilia, if they have frequent nose bleeding, postpartum bleeding, excessive bleeding after tooth extractions, or heavy bruising after mild trauma. Remember, anyone can get, I don't know why I have that here. Let me see something. Not sure if my lecture is getting ready to go into sickle cell. But while I'm here, I'll go ahead and just touch on this. Anyone can get sickle cell disease, although mostly African Americans. We want to talk to these patients about their current health problem. Yeah, I think the sickle cell just goes into family history and genetics. So we want to ask these patients about swollen lymph nodes, excessive bleeding and bruising. If bleeding was spontaneous or induced by trauma, you know, some patients they just bleed spontaneously because their clotting mechanism is impaired. We want to know about duration of bleeding after dental work is done. We want to check for dyspnea or shortness of breath with exertion, palpitations, frequent infections, fevers, recent weight loss, headache, and also paresthesia, that tingling sensation, a neural sensation. You want to also ask these patients if they feel fatigued, which can result from decreased oxygen delivery to cells. When O2 delivery to cells are reduced, cellular work decreases, and this results in fatigue, or fatigue actually increases. You want to ask if they're feeling more tired, if they need more rest, or if they're losing endurance during normal activities as well. That will cover our current health problems. So let's go ahead and get into our physical assessment. We are looking at the skin, head and neck, the respiratory system, cardiovascular, kidney and urinary, musculoskeletal, abdominal, central nervous system, as well as psychosocial. So we're assessing the whole. Assessing the whole body is important because of patients with blood problems, they do have reduced oxygen delivery and tissue perfusion to all organs. Remember, if these patients have hematologic problems or clotting issues, you want to handle them with care during caretaking, so as not to cause any further injury, such as bruising, petechiae, and excessive bleeding as well. As far as scanning, we want to look at the skin's mucous membrane for pallor, jaundice. Also look at the nail beds for pallor as well as cyanosis, pallor of gums and conjunctiva, or look at their palm creases, which can indicate decreased hemoglobin levels and poor tissue perfusion. Also take a read of page 802 as far as a skin assessment with these patients with the hematologic issues. As far as head and neck, we want to look at pallor, ulcerations of the oral mucosa. The tongue is typically smooth in patients with pernicious anemia, iron deficiency anemia, or smooth. And as far as iron deficiency anemia, their tongue can be smooth and beefy red with other nutritional deficiencies. Also read page 802 as far as head and neck assessment. As far as the respiratory system, blood problems that reduce oxygen delivery, it makes the lungs work harder to maintain tissue perfusion. We want to also, with these patients, you want to look at their rate and depth of respirations at rest, as well as during and after activity. Look for your easy fatigue, shortness of breath, or if these patients, they might need an extra pillow to sleep on at night as well because of that shortness of breath. And again, read page 802 for the respiratory assessment. As far as cardiovascular issues, blood problems that reduce oxygen delivery makes the heart work harder to maintain tissue perfusion. And so we want to look for things like a weak, thready pulses, distended neck veins, edema or phlebitis, and we want to also auscultate or listen to abnormal heart sounds in these patients. We want to also look for irregular rhythms. And again, take a look at page 802 to 803 for cardiac assessment as well. Now, as far as kidney and urinary, the kidneys have many blood vessels, so we want to look for hematuria. The color can be grossly red or dark brownish, gold urine color. Also remember, patients with a history of CKD, they do produce less natural erythropoietin and is often less anemic. And also, as far as musculoskeletal, we want to look for rib and sternal tenderness, as occurs with leukemia, which is a blood cancer. The bone marrow in this particular disorder, it overproduces cells, which increases the pressure in the bones. And take a look at page 803 regarding the musculoskeletal assessment. As far as abdominal, we're looking for an enlarged spleen. The spleen is not normally palpable, but when it is diseased, you'll be able to feel the spleen more easily. So when they have these hematologic issues, you will be able to palpate or feel the spleen. An enlarged spleen is tender, and they rupture. Now listen up, they rupture very easy. So you do not want to palpate too hard these patients when they have an enlarged spleen. A palpable liver can also point to hematologic problems as well. A common problem of bleeding, which is a common problem of bleeding in older adults, is chronic bleeding or intestinal polyps. So we want to prepare to test their stools for occult blood, as ulcers that are located in the stomach or small intestine is sometimes not visible to the naked eye. So make sure you read page 803 again for abdominal assessment. As far as central nervous system, there are neurological functions, or neurological functions can be impaired by hematologic issues. Example, we want to look for vitamin B12 deficiency, which impairs nerve function, and if severely deficient, it can cause permanent neurological degeneration. As far as our psychosocial assessment, we want to assess whether they have support, adequate support systems, looking at their financial resources, as these can impact adherence to therapy, as you know. And so read page 803 regarding the psychosocial assessment as well. So let's go ahead and get into our diagnostic tools that we have in order to determine what kind of condition your patients are in as far as their hematologic system. We're looking at things such as a CBC, INR, PT, PTT, those types of tests that we will discuss. Laboratory tests of cell number and function is possible through use of these tools. Make sure you know your ranges. This is very important that you know your ranges. Lab tests can provide definitive information about hematologic problems. So I want you to read chart 39-2 for more information on this. And again, know your ranges. Also note, if any patients are suspected of having hematologic issues require venipuncture, you just want to make sure you apply pressure for at least 5 minutes. One of the tests we will discuss is peripheral blood smear. Blood drop is spread over a slide, and it provides information on the size, the shape, and proportions of different blood cell types. And this is a pretty rapid test, so you may see them, well, you will see them doing these pretty often. Your CBC looks at red blood cells, all types of white blood cells, as well as your hemoglobin, your platelets as well. So a slew of different blood components. The reticulocyte count, it looks at bone marrow function. Reticulocytes are immature red blood cells with a nucleus. If a patient has too many, it indicates that bone marrows are releasing them before they mature, which the bone marrow shouldn't be doing that. Also, we're looking at platelet count, or platelets are known as thrombocyte count. A low value is called thrombocytopenia, and the patients are at greatest risk of bleeding as the platelets are critically low for the clotting cascade process. Remember, you need the platelet process, a plug, in order for the clotting cascade to work, to be activated. And so we also have the hemoglobin electrophoresis. This detects abnormal forms of hemoglobin like the S in sickle cell disease. We also have a Coombs test. It is referred to direct and indirect. A direct test is used for blood typing, the AB, AB, O, and so forth. And what it does is it detects antibodies that uh, might work against the red blood cells that may be attached to the patient's red blood cells. So too many can result in what we refer to as a hemolytic anemia or destruction of the red blood cells. Um, and the indirect test, it detects the presence of circulating antiglobulins. The test looks to see if patients has antibodies to types of red blood cells they're about to receive. Now, the serum ferritin, it is the amount of free iron in the plasma. You also have transferrin. It is the amount of iron that can be transported to cell storage sites, such as like your spleen, for example. And you also have the TIBC. It is a blood test to see if you have too much or too little iron in your blood. It measures essentially the iron levels. Abnormal levels can occur with iron deficiency anemias as well. And so we continue our diagnostic testing, um, laboratory tests measuring bleeding and coagulation. And this speaks to our PT, PTT mostly or mainly. Your PT measures how long it takes for blood to clot, which reflects the number of clotting factors like clotting factors such as number 2, 5, 7, and 10, and how well they are functioning. The INR, it measures the same process as the PT above that I just mentioned, establishing a normal mean or standard for the PT. So patients on Coumadin or warfarin, they need their INR range between 2 to 3 in order to prevent blood clots. Now, the partial prothrombin plastin or the PTT, it assesses the intrinsic clotting cascade and actions of factors 2, 5, 8, 9, 11, and 12. If the PTT is prolonged, there is a deficiency in these factors that I just mentioned, like hemophilia or DIC. DIC is referred to as disseminated intravascular coagulation. All this coagulation is taking place, which we won't discuss now. For example, factors 2, 9, and 10 are vitamin K dependent. They're produced in the liver. Patients with liver disease can have a prolonged PTT. Normal range is between 60 to 70 seconds. Now, you also have the anti-factor 10A test. It measures the amount of anti-activated factor 10 or anti-XA in the blood. And this is affected by heparin. And so this is used to monitor heparin levels in patients and in patient treatment with different types of heparin. And we also have a platelet aggregation, and this is the ability to for the platelets to clump. This is tested by mixing the patient's plasma with an agonist substance that cause clumping. Now, aggregation or clumping is the same thing, can be impaired in conditions like von Willebrand disease, also in use with patients who are taking aspirin, and those who are taking anti-inflammatory agents, psychotropic agents, as well as platelet inhibitors as well. So these are some other diagnostic tests, imaging assessment tools that we use, the radio isotopic imaging, and also standard x-rays. Certain tests can determine hematologic dysfunction. The radioisotopic imaging isotopes can evaluate bone marrow sites for active blood cell formation and iron storage. Radioactive colloids can determine organ size, liver, and spleen function. Our standard x-rays, they can determine some hematologic disorders. For example, x-ray of the bones can tell your physician if destruction as seen in multiple myeloma is present. Because it has a kind of a Swiss cheese appearance. So now we move our attention to bone marrow aspiration and biopsy. You would have to assist your physician at the bedside, typically with this procedure. So we'll talk about patient preparation, the procedure itself. We want to also talk about follow-up care in that we are observing for excessive bleeding, we're monitoring for infection and bleeding for about 24 hours. These patients might require a mild analgesic due to the pain that this procedure that is caused from this procedure. If the patients are discharged after the procedure, these patients should be taught to observe the site every 2 hours for the first 24 hours for active bleeding or bruising. And of course, they're supposed to limit activity for 48 hours in order to prevent trauma. So going into it a little further, when patients have possible problems in their blood cell production or maturation, a bone marrow biopsy or aspiration is done to rule out or to rule in hematologic issues. It provides data about the bone marrow function. As far as patient preparation, we want to support and provide education about the procedure. We want to tell them an anesthetic agent will be injected and it will feel like a stinging or a burning sensation. They will have a heavy feeling sensation. Or they will feel a heavy sensation of pushing and pressure as the needle is inserted. You might, well, not might, but you want them to know that those are all a part of the procedure as well. Now, these patients may hear a crunch sound or a scraping sensation as the needle enters the bone. So you want to inform them of that as well. There's a brief sensation of painful pulling felt as contents are being aspirated through the needle, the bone marrow contents. Now, if a biopsy is being done, the patient feel more discomfort as the needle is rotated into the bone. So you're actually rotating this device into the patient's bone. If the iliac crest is used, we want to place these patients in the prone or side-lying position. The procedure, getting into the procedure, it does last for about 5 to 15 minutes. Anesthesia is used and a mild tranquilizer may be used as well. Want you to also look at page 806 for information on the procedure and follow-up care. So I'll go ahead and let you read the rest of that. Not very difficult, and just let me know if you have any questions. So the study of bone marrow can be used to identify the presence of leukemia or other malignancies, or to determine the cause of anemia. So this is why bone marrow aspirations are so important. And I think that is it. Make sure you also take a look at these questions as well. Just go through them and just make sure you know them. They're quite relevant to the information I just went over. And so hopefully this presentation will provide you with that additional information you need to help you um, do well on your test and that is upcoming. And again, if you have any questions, please let me know.